all attendees. If you're having a technical issue, you can click on Adriana Avalar's name among the attendee section and send a message by choosing private chat. With that, let's start the webinar. As mentioned, this is a WIN Collaborative monthly webinar. The WIN Collaborative has 8 key features that patient-centered medical homes incorporate. This topic supports engaged leadership, quality improvement strategies specifically, patient-centered interactions, organized evidence-based care, care coordination, and continuous team-based health relationships. So we'll go on to our agenda for today. We'll begin with a short introduction, and then we'll start the webinar presentation from Cheryl Farmer, MD. At the end of the presentation, we'll have time for you to ask questions. Before we end today's session, there will be a short evaluation where you will then receive your certificate of completion for attending today's webinar. So I'd like to start off by introducing Cheryl Farmer. It's my great pleasure to do so. I've been able to work with Cheryl for the past more than 6 months. We're getting close to a year now. And she's the heart disease and stroke prevention specialist with a particular focus on hypertension. She's our lead in promoting the Million Hearts Initiative to prevent 1 million heart attacks and strokes by 2017. And Cheryl brings both clinical and community expertise to her role. She earned her MD at University of North Carolina at Chapel Hill School of Medicine and a family medicine internship in Pennsylvania at the Lehigh Valley Hospital. Cheryl is extremely knowledgeable about clinical care, chronic disease management, pharmacotherapy, and medical office and hospital protocols and procedures. And she has a great deal of experience working with people from diverse cultural, socioeconomic, educational, and professional backgrounds across the lifespan. So I'd like to hand it over to Cheryl now.
Thank you, Sarah Eve. Well, good morning, everyone, and thank you for attending this webinar today. It is my hope that through today's webinar that I show the effectiveness and importance of utilizing team-based care for the management of hypertension. I want to thank Jennifer Johnson-Jofield, Peninsula Community Health Services, for sharing documents and information. And I also want to thank Angela Kemple, our DOH Heart Disease, Stroke, and Diabetes Prevention Program epidemiologist, for compiling the data for this webinar. I have identified 3 objectives for today's webinar, and they are: we want to understand the current health burden of hypertension, increase awareness of best practices and/or evidence-based programs for hypertension control, and increase your comfort with engaging your patients and identifying barriers to improved health outcomes. So let's get started today with today's topic by taking a quick poll. This will give us a general idea about how much work is being done with hypertension. So take a few seconds to answer, please.
While people are finishing voting, I neglected to mention that there are some resources, additional resources that are available in the download box. You'll find the resources that Cheryl's talked about and today, and a copy of today's slides.
Okay. Thank you for participating in this poll, and it looks like the majority are working with hypertension in their practices, which is great, 50 to 74% of the work that you're doing. So this will be hopefully a great webinar for you. Hypertension is a global, national, and statewide concern. It is the most common diagnosis seen in primary care and affects about 1 in 3 adults. Hypertension is the second most common risk factor for kidney disease after diabetes. This slide reminds us of how significant hypertension is as a risk factor for cardiovascular disease. Cardiovascular disease is the leading cause of death for men and women in the United States, accounting for 1 in 3 deaths, and the annual national costs are estimated to be at about $315.4 billion. So when we look at what is happening in our state and to our residents, this is what we are seeing. Looking at this data, we see that heart disease and stroke are currently the 2nd and 6th leading causes of death, respectively. These two conditions were the number 1 cause of death for Washingtonians, representing a quarter of all deaths in 2013. So when we try to understand the impact, it is important for us to consider healthcare costs for heart disease and stroke, as I previously mentioned, costing over $300 billion annually. Also remember that they are the leading causes of preventable death in people 40 to 65 years of age, and that more than 2 million heart attacks and strokes occur each year. This is why hypertension is so important. It is a major risk factor for heart disease and stroke. Less than 50% of people diagnosed with hypertension have achieved blood pressure control, which means that more than 35 million Americans are at risk for complications due to hypertension. Hypertension exacerbates chronic conditions such as diabetes, renal disease, coronary artery disease, heart failure, and can lead to a shortened life expectancy. Worldwide, hypertension is the most important risk factor and the leading cause of death due to cardiovascular diseases. Globally, it is directly responsible for half of all deaths due to heart disease and 2/3 of cerebrovascular accidents or strokes. Nationally, nearly 1/3 of the adult population has hypertension. The prevalence of measured hypertension has shown no significant improvement in more than a decade. Clearly, we cannot talk about hypertension without also talking about prehypertension. If prehypertension is not treated, it can progress onward into hypertension. A review of our most available data reports that prehypertension affects 25% of our national population. Prehypertension is important because even at this early stage, research shows that vascular damage is already occurring. This slide portrays the notable differences in self-reported hypertension by race and Hispanic origin, level of education, and annual household income. As depicted in the chart, after adjusting for age, self-reported hypertension was significantly higher in the Black or African American group than other racial and ethnic groups. This is similar to national patterns. After adjusting for age, people of lower socioeconomic position, as measured by income and education, are more likely to report having high blood pressure. Differences in health behaviors, access to preventive health care services, access to material and social environments that make healthy behaviors easier to adopt, and effects of chronic stress, which can include stress experience due strictly to discrimination and poverty, may account for the associations we have observed between the socioeconomic position and the self-reported hypertension. In 2013, over 2/3, about 68%, of Washington adults who self-reported hypertension were currently using antihypertensive medications to lower or control their high blood pressure. Even after adjusting for age, this is lower than the national percent, as depicted in the chart. Antihypertensive medication use was significantly higher among adults 65 years and older compared to those who are 45 to 64 years old as 18 to 44 years old. Among women compared with men, and among non-Hispanic blacks compared with Hispanics. At this time, notable differences by income or education level were not observed. So if we're going to address hypertension, it is important to have clear parameters for diagnosing hypertension. This slide and the next are examples of protocols used for the diagnosis of hypertension. This algorithm is used by the Institute for Clinical Systems and Improvement. And this algorithm is used for diagnosis of hypertension in Canada. The articles that reference both of these diagrams are available in the download box to the left of your screen. Here's how the American Heart Association categorizes hypertension as well as prehypertension. This is a chart from the JNC that shows the recommendations to follow for blood pressure follow-up. The article from which this chart was created is also available in the download box to the left. As a reminder, although we tend to associate cardiovascular disease with men, it is important to remember that women are also affected by this condition. As women get older, the prevalence increases. Uncontrolled hypertension may be even more likely to be overlooked in women than in men. As we think about the management of hypertension for our patients, let's frame our approach to care within the patient-centered medical home model. In doing this, not only will we address hypertension, but the other medical conditions patients face as well. The PCMH model provides team-based care that revolves around the patient and family. This model will facilitate you working as a team to care and support each patient without increasing the burden on any one person. PCMH puts the patient and the family/supports at the center of the healthcare system, as you can see in this image, and provides primary care that is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally appropriate. This model treats people and their families the way they want to be treated in sickness and in health. This is the work offered, promoted, and supported by the Department of Health's Washington Healthcare Improvement Network, also known as WIN. And for the past 4 years, WIN has been offering patient-centered medical home coaching and training to primary care practice teams around the state. Remember that this model of care uses data to continuously improve. Now, we're ready for our second poll. Please take a few seconds to answer this question. How does your organization identify and follow your patients with hypertension? Okay, thank you for participating in the poll. And it looks from the results that we're able to see that the majority